Welcome to the deep dive. Today we're taking a look inside the body's control room. We're talking internal diagnostics, kidney function, electrolytes, blood composition. We want to break it all down.
Yeah, the sources we've got are pretty dense. Everything from, nephron deep dives to handling potassium emergencies. Our goal here is to give you that shortcut, that real understanding, not just what the lab number is, but what it actually means for health.
That's it exactly. These tests, they aren't just static figures on a page. Think of them more like dynamic snapshots. They show how the body's incredibly complex systems are always working, always adjusting to maintain balance. Homeostasis. And if you understand the nuances, the pitfalls, the exceptions, well, then these labs really do become windows into vital functions.
Okay, great. So let's start with, well, the kidneys. Real multitaskers. We often just think filtration, right? That happens in the nephron, that tiny unit filtering blood in the glomerulus. But what else are they up to? What gets overlooked? Oh, a lot. They're like the body's ultimate control tower. Sure, excretion of waste like urea, creatinine, that's key. But they also manage acid-base balance, regulate blood pressure, control plasma osmolarity, and importantly, they have hormonal jobs too, activating vitamin D, producing epoetin for red blood cell production. They're absolutely central.
Okay. Now for, decades, the main tool we've used to check that filtration has been serum creatinine. SCR. It's just a waste product from muscles. But the sources we looked at are really clear. SCR alone. It shouldn't be the only thing you look at for kidney health. Why is it so, well, potentially dangerous to rely on just that?
Because the level of creatinine you find is almost entirely dependent on the factory producing it, which is your skeletal muscle mass. That's the crucial point, the thing that often trips people up. Think about it. A huge bodybuilder might have a normal creatinine around, say, 1.2 milli-GDL, but a frail elderly woman, her normal could be down to 0.4.
Wait, hang on. So if someone is elderly or maybe malnourished, they don't have much muscle, they produce less waste, doesn't that make their creatinine number look artificially low?
Precisely. That's the trap. Their body makes less SCR, so the lab result might come back looking, fine. Maybe 0.7 milli-GDL looks normal. But because their baseline production is so low, that seemingly normal number could actually mean their kidney filtration rate, their GFR, is dangerously low. They might be in renal failure, quietly. And the creatinine test itself is actively overestimating how well their kidneys are working. It's a serious warning sign disguised as a normal result.
Right. That's a huge pitfall.
So we need something better, something that isn't affected by muscle mass or diet. And that's where this other marker, cystatin C, comes in. Cystatin C is a much better indicator in many cases. It's a small protein produced at a steady rate by basically all cells with a nucleus. This means its production isn't really swayed by muscle mass, age, or high-protein diets like creatinine is. So for those complex cases, the elderly, cancer patients, people on specific diets, cystatin C gives a much more reliable, muscle-independent view of the kidney's actual filtration power.
Okay, that makes a lot of sense. Moving on from blood tests. If the kidneys aren't doing their job right, or if there's something else going on systemically, the evidence shows up in the output, right? In the urine. Urinalysis, it starts just by looking at it. Macroscopic view, let's talk color. Because I think everyone's had that beet scare moment. You panic thinking something awful is happening because your urine looks pinkish or red.
Exactly. And that little moment of panic shows why color is important, even if the cause turns out benign, like beets. But that red to orange color, it could be beets, could be drugs like rifampin, or it could be something serious like myoglobin, that's muscle protein spilling out, typically from crush injuries, rhabdomyolysis, life-threatening stuff.
Okay. What about some of the weirder colors, like blue or green? Is that a thing?
It is. Blue to green can happen if bilirubin oxidizes to biliverdin. Maybe the sample wasn't stored right. Or it could be certain dyes or chemicals. The antidepressant amitriptyline or methylene blue can do it. Brown to black is usually the most concerning, though. That could mean melanin, maybe from melanoma if the urine sets out, or bile pigments, or even drugs like metronidazole.
Okay, colors give clues. Now looking closer, under the microscope. Casts. You mentioned casts. What are they and why is finding them such a big deal?
Casts are fascinating. They're basically tiny cylindrical molds formed inside the kidney tubules themselves. When protein or cells clump together in those narrow tubes and they get flushed out, they keep that shape. Finding them tells you exactly where the injury or inflammation is happening within the kidney. It's highly specific.
So it pinpoints the problem area.
Precisely. See red blood cell casts. You're almost certainly looking at damage to the glomerulus, the filter itself, classic sign of acute glomerulonephritis. White blood cell casts, on the other hand, usually points towards pyelonephritis, that's a kidney infection. Tubular epithelial cell casts suggest damage to the tubule cells themselves, maybe from acute tubular necrosis, ATN, often caused by toxins or lack of blood flow.
And what's the really bad sign, the one you don't want to see?
That would be waxy casts, sometimes called broadcasts. These indicate that urine flow through the tubules is really slow and sluggish, and the tubules themselves are widened and damaged. It usually means advanced chronic kidney failure. Not good news.
Okay, and then there's the dipstick test, right? Quick chemical checks. Let's pick out two key ones. First, nitrate.
Yep, nitrite. A positive result is a very strong indicator of a urinary tract infection, a UTI. Specifically, it means bacteria are present that can convert nitrates, which are normally in urine, into nitrites. E. coli is the common culprit here. It's a great quick screen, but sometimes you need that first morning sample because the bacteria need a bit of time, incubating in the bladder to actually do the conversion.
Got it. And the other one, urobilinogen. Our sources mentioned this can be a subtle clue for early liver issues.
Yes, that's an interesting one. Elevated urobilinogen can be an early sign of liver cell injury, like in hepatitis. But here's the crucial distinction. If urobilinogen is high, but there's no bilirubin found in the urine dipstick as well, it actually points away from the liver. Instead, it suggests a hemolytic process, meaning red blood cells are being broken down somewhere else in the body too quickly.
Okay, subtle but important difference there.
Definitely. Context is everything.
All right, let's shift gears a bit. From waste processing to fine-tuning the internal environment, electrolytes. Specifically, sodium and potassium. Small changes here can become big emergencies fast.
Absolutely critical areas. Hyponatremia, low sodium is incredibly common, especially in hospitals. We categorize it based on the patient's fluid status. Are they dehydrated, hypovolemic? Do they just have too much water relative to salt, euvolemic, like in SIDH? Or are they overloaded with both salt and water, hypervolemic, like in heart failure or cirrhosis? But really, the symptoms dictate the urgency. Below 125 milliview QL, things get serious confusion, seizures, vomiting, even coma.
And this is where treatment gets tricky, right? The treatment tightrope you mentioned.
Exactly. The absolute first thing you must figure out is this acute hyponatremia, meaning it developed fast, less than 48 hours ago? Or is it chronic? Because if it's acute and the patient has symptoms like seizures, it's a neurological emergency. The brain is swelling. You need to give 3% hypertonic saline, usually a rapid 100 millimole bolus, to quickly bump up the sodium level by maybe 4-6 MEQL and stop that swelling urgently.
Okay, urgent action for acute. But if it's chronic, if we correct it that fast in a chronic case, what happens? You mentioned a huge warning.
The massive warning is osmotic demyelination syndrome, ODS. It's devastating. If the low sodium has been there for a while, longer than 48 hours, the brain cells have adapted. They've adjusted their internal osmolarity to match the low sodium outside. If you then raise the external sodium level too quickly, water rushes out of those adaptive brain cells. They shrink violently, causing demyelination, stripping the protective coating off nerve fibers. Permanent neurological damage. So chronic hyponatremia must be corrected slowly, very, very slowly. The duration acute versus chronic completely changes the game, the risk, and the speed of treatment.
Wow. That is, stark reminder of the balance. Okay, moving to potassium. Critical for muscle function, especially the heart. High potassium hyperkalemia seems like the biggest cardiac worry.
It is. Potassium levels above, say, 6.5 mQL start causing serious electrical instability in the heart. You see it on the ECG. First, those tall peak T waves. Then the P waves might disappear. Then the QRS complex widens out. That's heading towards ventricular fibrillation if you don't intervene immediately. It's a true emergency.
So, hyperkalemic emergency. Someone comes in, ECG looks bad, potassium is high. What's the very first thing we do? Is it trying to lower the potassium straight away? I thought maybe giving calcium was risky.
That's a common point of confusion, but the sequence is critical. The absolute first step isn't lowering the potassium. It's giving IV calcium, either calcium gluconate or calcium chloride. Why? Because the high potassium makes the heart muscle cell membranes hyperexcitable, ready to trigger dangerous arrhythmias. Calcium doesn't lower the potassium, but it stabilizes that cardiac membrane. It acts like a shield, protecting the heart from the potassium's dangerous effects.
Okay, so calcium buys time, protects the heart first.
Exactly. It buys you crucial minutes. Then, once the membrane is stabilized, you move to things that actually lower the potassium level in the blood, like giving insulin and glucose together. Insulin drives potassium back into the cells, out of the bloodstream.
Got it. Stabilize, then shift. Makes sense. Okay, let's do some diagnostic quick hits now, touching on the liver and blood. First, liver function tests, LFTs. Our sources pointed out that name is, well, kind of a misnomer.
It really is. LFTs mostly measure liver cell injury, like ALT and AST, which leak out when liver cells are damaged. Or they measure cholestasis, problems with bile flow like ALP and GGT and bilirubin. They tell you the liver's inflamed or stressed, yes. But they don't always tell you how well the liver is actually performing its essential functions, like synthesis.
Okay, so if LFTs measure damage more than function, what's the best single lab test to quickly gauge if the liver has actually failed at its job, its synthetic function?
For a quick assessment of synthetic function, the prothrombin time, or PTINR, is probably the most valuable. The liver makes most of our clotting factors, and some of these have very short half-lives, just hours for factor VII. So if a patient has a prolonged PTINR, meaning their blood takes longer to clot, you give them a shot of vitamin K, which the liver needs to make some factors. If the PTINR doesn't improve after getting vitamin K, that's a very strong, quick indicator of severe liver failure. The factor just isn't working. If it does normalize after vitamin K, the problem was more likely just poor absorption of the vitamin, not liver failure itself.
That's a really neat functional test, actually. Okay, sticking with the liver briefly, if labs show isolated hyperbilirubinemia, just high bilirubin, why is it crucial to fractionate it to see what type it is?
Because the type tells you where the problem lies. Is it predominantly unconjugated bilirubin? That means the liver hasn't processed it yet. This often points to increased breakdown of red blood cells, or maybe a genetic thing like Gilbert syndrome. But if it's predominantly conjugated bilirubin, that means the liver did process it correctly, but can't get rid of it, it can't excrete it into the bile. This usually signals a blockage somewhere in the bile ducts, and you need to look for that obstruction, typically starting with an ultrasound of the right upper quadrant.
Right, direct's the next step. Okay, shifting finally to hematology, red blood cell indices, specifically the mean corpuscular volume, MCV. How does that help narrow things down instantly?
MCV is super useful. It just tells you the average size of the patient's red blood cells. It creates an immediate classification. Are the cells small, microcytic, MCV less than or equal to 80? Think iron deficiency or thalassemia usually. Are the cells large, macrocytic, MCV greater than or equal to 100? Think vitamin B12 or folate deficiency, maybe liver disease or certain meds. It's often the fastest way to start figuring out why someone is anemic. Simple but powerful. Okay, last point. Hemostasis, clotting. We know there's primary hemostasis, the platelets forming a quick plug, and secondary hemostasis, the whole coagulation cascade making a stable fibrin clot. When tests mention D-dimers, what exactly is that measuring in this process?
D-dimers are specific breakdown products. When a fibrin clot is formed, that's secondary hemostasis, the body also has systems to eventually break that clot down once it's done its job. That process is called fibrinolysis. D-dimers are fragments left over after fibrinolysis has occurred. So a high D-dimer level doesn't measure clot formation itself. It measures the cleanup after a clot has formed and is being broken down. It tells you there's been significant clotting and subsequent breakdown happening somewhere.
Got it. So evidence of the whole cycle. We have definitely covered a lot of ground today. It really highlights how you can't just look at a number in isolation, doesn't it? Things like, well, needing cystatin C instead of creatinine sometimes, or the critical difference in speed for fixing low sodium, or why calcium comes first in that potassium emergency. These details are absolutely key to using these tests properly.
Absolutely. The big takeaway is interconnectedness. It's all dynamic. You can't really wall off these systems. Kidney problems mess with potassium, calcium, acid base. Liver function impacts clotting directly. These lab results, they only truly make sense when you see them as data points within this huge integrated network that is the human body.
So that brings us to our final thought for you, the listener, to maybe mull over. We learned today that something as simple as how much muscle someone has can totally change what a creatinine number means. Considering this, deep dependence on the patient's wider state, their metabolism, their build, what do you think is the single most misleading routine lab result you see regularly? And what single piece of non-lab info, maybe hydration status, diet history, even just knowing what meds they're on, do you believe should always come with it to make sure we interpret it right? Something to think about. Keep digging deeper.